be talking this morning about option B plus and maternal engagement in care. And my brief from Mark Cotton was to talk about outcomes. And I thought outcomes sounded far too broad and nonspecific, and so I've honed down into maternal engagement in care in particular for the reasons that I specified. I'll start out with a quick background where we are with option B plus. Chewy did a wonderful job of it yesterday, and I'll race through that. And then I'll slow down and pause around a few key concepts that I think we need to keep in mind, considerations that we need to hold with us when we think about maternal engagement in care during pregnancy and postpartum. And then I'll review some of the recent evidence for engagement and disengagement from care among pregnant and postpartum women under option B+, and then look at the drivers, the causes of that disengagement and the interventions which may be indicated in turn, and then wrap up with some thoughts and opinions, really, about where we're headed. So first, by way of background. Chewy showed this slide yesterday and noted that the rollout of option B+ and the incorporation of option B+ into national policies has been a tremendous success, an overwhelming success over the last 5 years. And what we've seen and what's well known to this audience during that time are dramatic increases in ART coverage during pregnancy under option B+. These data for the Malawi National Program shown at CROI this year, showing, as we're probably all familiar with, an incredible uptick in ART initiation during pregnancy and continuation during breastfeeding, largely. And also shown at CROI this year are data from Swaziland, describing in a unique experiment the transition from option A to option B+. And what we can see here is in the stepped wedge evaluation, under option A, 35% of women, approximately, in the public sector clinics that participated, initiated ART during pregnancy. That's by indication, of course, and increased to 94% under option B+. But importantly, among women with low CD4 cell counts, CD4 is less than 350, who should be initiating ART under option A, 2/3 approximately were doing so under option A, and that increased also to 94% under option B+. So option B+ has done a spectacular job of reaching the women and the pregnancies in greatest need. And in the build-up and the rollout of option B+, we were promised that ART initiation would simplify. And this has, for me, been a bit of an epiphany. Without CD4 counts, without with other interventions in place, ART becomes so simple that same-day initiation, the initiation of ART at a woman's first antenatal visit, becomes possible. And we see this happening in Malawi, we see it in Zimbabwe, we see it in South Africa. We can debate whether or not this is a good thing, but it really has been a revelation. And so we're in option B+, and there's no turning back. One of the things that we've seen over the last few years is a wonderful cottage industry building around option B+ in cost effectiveness and effectiveness modeling. Mathematical modelers examining the potential impacts of option B+, and cost effectiveness, I suppose health economists examining under what conditions option B+ would be cost effective. And so there's a whole cottage industry, a slew of publications over the last 2 years in this. And one of the things that's been pointed out very recently is that the vast majority of these models assume very high levels of women initiating ART during pregnancy, being retained in care, being adherent to ART, and remaining virologically suppressed over the reference period. And so here a flag perhaps goes up, and this may be a set of assumptions that we need to think critically about. So now, some key concepts, some key considerations that I think are worth keeping in mind. The first, and this comes from the general adult ART literature, it's not pregnancy specific by any means. We've used over the last decade a wide range of terms to describe the phenomenon of engagement in care. We talk about adherence, retention, defaulting, loss to follow-up, attrition, and so forth, disengagement. And one of the things that's become clear from me, at least, drawing on adherence literature that's not HIV specific by any means, is that these constructs that we describe and that we study are really a spectrum of behaviors. For instance, pill taking, visit attendance and missed visits, late visits, and retention and care exist along a spectrum of behaviors. And indeed, they're separate but closely correlated manifestations of the same underlying behavioral and systemic phenomena. And again, this isn't a revelation from HIV. This is adherence science writ large. And to give you a sense of that, these data come from chronic diseases, chronic medications tracking database from the United States, and it's not HIV specific. But we see in this review publication, these data were presented for the first time, the phenomenon that non-adherence to a chronic medication is a potent predictor of subsequent defaulting. Now, in practice, that makes great sense, but in our programmatic vision, we don't necessarily link these phenomena directly. The second consideration that I want to sort of plant the seed for before we look at the evidence is thinking about pregnancy and the postpartum period as being comprised of a series of major life events in a way that other patient populations on ART perhaps don't experience, arguably. And the major life events experienced during pregnancy and the postpartum period are driven in physiologic domains, psychological factors, and social and economic and sort of structural considerations. But we're starting to parse out distinct periods around pregnancy, labor and delivery, the early postpartum period, and then the late postpartum period. And you'll note that breastfeeding straddles those periods because I've been well trained. And we can start to think about the determinants of adherence and patterns of adherence and engagement of care as being affected by these life events taking place in an incredibly short span of time, if we think about the adult life course. And just so I'm not accused of being afraid of men, you'll note this focuses on women and children, but there is a man lingering somewhere in the corner. He, of course, is responsible for the repeat pregnancy. And the third consideration that I think we need to hold as we think about this, this literature and the evidence that we're seeing is the complexity that we are in part responsible for as clinicians, as programmers, as policymakers, the complexity of health systems and health services that pregnant women, postpartum women, and their children have to navigate around HIV care and treatment. Now, the exact structure of this complexity, of course, varies between health systems. But it's not at all uncommon in this country and in many urban centers across the continent for a woman to be forced to navigate antenatal care, which may be separate from obstetric and delivery care, and is often separate from well baby postpartum, routine postpartum care, hopefully including early infant diagnosis services. And all of this potentially operating separately from quote-unquote general adult ART services. And now as we start to think about differentiated models of care as well, there's another level of complexity in the health services which patients are forced to navigate. And this is our responsibility. This doesn't exist in the ether. This is what the health system creates. So now I want to turn to some of the evidence around engagement of care under option B+. So these data were presented, I think, earlier this year at CROI or last year at CROI and then published earlier this year. The long-term follow-up of option B+ cohorts in Malawi. And what we see is that, three cohorts of women were analyzed. Women initiating ART during pregnancy, a smaller number of women initiating ART during breastfeeding, and then a cohort of women initiating ART for their own health outside the context of pregnancy. And what we see quite clearly here is that there's more blue representing loss to follow-up and pinkish red representing no follow-up in women initiating ART during pregnancy compared to women initiating ART for their own HIV disease. In fact, women initiating ART during pregnancy were 5 times more likely to have no follow-up and 1.5 times likely approximately to be lost to follow-up during the first year on ART. And these data are not isolated, and it's one of the points that I'll try to get across. These data come from a totally different design, a health system survey of 186 facilities in Uganda under ODA. And what you can see here is that in almost 2,000 patients initiating ART across these facilities, there's a large drop-off in retention between ART initiation and the first postpartum visit, and further attrition in the first 7 months after ART initiation. So we've seen it in the previous slide in Malawi, we see it in Uganda, we see it in many places. And I'll come back to that Swazi evaluation I referred to earlier, because it provides an interesting insight into what may be driving some of this non-retention. So this, again, is from a stepped wedge evaluation, transitioning from option A to option B plus at 10 health facilities across Swaziland. And I want to focus in on postnatal retention. And what we see is in the transition from option A to option B plus, first, levels of retention through 6 months postpartum are almost shockingly low. And this is itself problematic. But we do see an almost, or a substantial increase in retention under option B plus compared to option A. But when we restrict that analysis to women who initiated ART during pregnancy, it's obviously a much smaller cohort under option A by design than under option B plus. What we see is that, in fact, retention in the early postpartum period under option A appeared to be slightly better than it was under option B plus, noting that the numbers of patients involved are, of course, much smaller. And this phenomenon, we think we may observe in other places if we look for it, and it was remarkably consistent across sites in Swaziland. Now, we don't have a lot of data on adherence and viremia, which, if we think about these as a spectrum of behaviors, should go hand in hand. One of the few insights comes from a routine care cohort in Cape Town, which followed 620 women initiating ART under option B plus, who also received intensive viral load monitoring that was batched and not used to inform care beyond the standard of care viral load monitoring in South Africa. The median gestation at ART initiation was about 20 weeks. We see here rapid viral suppression in this cohort, and in fact, over 90% of women achieved a viral load below 1,000 copies per mil by the time of delivery. But then, postpartum, we see this kick up in viremia. And in fact, by 12 months postpartum, we found that almost a third of women had experienced viral loads above 1,000 copies per mil. And this goes hand in hand and fits with the data that we saw earlier around retention. Remember, this is a spectrum of behaviors around engagement and care, and just as women are dropping out of care, it makes sense that viral loads are escalating or elevating. Now, all the data I've shown you comes from sub-Saharan Africa, a few different countries. And I want to point out that this is a global phenomenon, I would argue. These are data published recently from the US and from the UK and Ireland cohort. And what we see on the left is that in a cohort of women receiving HIV care, mostly ART, but not entirely, mostly ART care in Philadelphia in the late noughts, only a third of women who received HIV care during pregnancy remained virally suppressed up to 1 year postpartum. In the UK and Ireland cohort, a different design found that about 40% of women who were virally suppressed at delivery, as we saw in the previous slide from Cape Town, experienced viral rebound through 1 year postpartum. And so when you put this together, I want to return to this slide from the recently released report. The rollout of option B plus has been a massive policy success. What's followed in its wake are reports across countries suggesting that there are substantial challenges in the engagement of pregnant and postpartum women in care under option B plus. And so I've put red stars here for all the countries that I could find articles for in PubMed in a cursory search. And so it is somewhat sobering, perhaps. And in turn, it's good to look at the drivers and the interventions that we may, the drivers of this phenomenon and the interventions we may use. And I have to pause here for a moment, And I have to share with you a warning. And the warning is that there's not a lot of data here. And based on what we've seen on the previous slides, there's in fact perhaps a frightening absence of data. We can understand conceptually the drivers of disengagement at a level of organization, sort of clinical and biological phenomenon, social and demographic, psychological phenomena sort of within the individual, and then structural considerations like health services and health systems. One of the big questions in the clinical and biological sphere is the potential role of side effects in contributing to non-adherence, disengagement from care. There's not a lot of data here, but we know that there's a heavy burden of symptoms and side effects experienced by HIV-infected women during pregnancy. Parsing out the etiology of those is difficult. And we know certainly that the total side effect burden, at least in one cohort, appears associated with non-adherence. And there's qualitative evidence from Malawi as well, suggesting that side effects do loom large for many women. The risk factor data, sort of the traditional epidemiologic data on this question, understanding the causes of disengagement from care, are surprisingly unfulfilling, unsatisfying. And the reason is that they're highly heterogeneous and the drivers of non-retention appear to be massively contextual. So there are some, quote unquote, risk factors which appear consistently. Younger age, recency of HIV diagnosis, concerns around cost for many women, and importantly, unintended pregnancies for the index pregnancy. But there's mixed evidence around many more potential risk factors on which we could intervene. The question of ART readiness related to same-day initiation, the potential for male partner involvement, disclosure as a potential positive or negative factor affecting adherence, and depression and mental illness. And here the qualitative literature are actually much more interesting. I want to come back to what we can control perhaps a little bit more, health services and health systems factors. We know from many conditions that in fact the structure of health services and health systems shapes the ability of patients to engage in care. But I would argue that women are especially vulnerable to the nuances of healthcare services as they negotiate this, what we saw before, this sort of complex web of health services during pregnancy and postpartum. And there is a little bit of data starting to explore this. This study comes from Malawi, it's published in JIS in 2014, examining the impact of models of healthcare services on early postpartum retention. It was a district-level health facility survey coupled with a cohort analysis of routine data in Malawi. And the investigators identified sort of the organic development of 4 distinct models of care for caring for pregnant and postpartum women and their children. And the models varied importantly on the site of antenatal ART initiation and the site of follow-up and transfer, and the role of transfer during the postpartum period. And the study found that somewhere between 10 and 20% of women had defaulted from option B+ by 6 months postpartum, which is consistent with the other data at a year. And the strongest associations involved the models of care involved. Retention was lowest in facilities with ART initiation in the ANC that then referred women for separate follow-up. So when we take a step back, we don't know all that much about the drivers of disengagement under option B+. We have a mosaic or a bit of a patchwork understanding. Our insights are scattered, our gaps in knowledge loom large. We do have a sense that the factors involved are diverse, and they range widely across contexts, and this should be unsurprising. We have a universal policy for people like us who are not universal. And so thinking about interventions in this context is a challenge. There are loads of exciting ideas for interventions to promote engagement in care in pregnant and postpartum women under option B+. There are ideas around enhanced patient education and counseling, engaging women in the MCH setting indefinitely, enhanced peer support, home support, male partner involvement, mHealth, directly observed therapy. I withhold judgment of all these ideas, for the record. Adherence clubs are sexy at the moment, and they're coming into postpartum women. Conditional cash transfers, again, I withhold judgment. Case manager systems. So there are all these exciting ideas. And this is a wave of implementation science that's coming to the fore, and it's really exciting. However, right now there are few data from the option B plus era. When you look at what's the evidence for these interventions, the duration of effect, as it were, is quite modest, and the effect sizes involved are quite modest. And we'll have to look quite closely and think quite carefully about cost and cost effectiveness in that context. But importantly, most of our intervention strategies at the moment target single specific issues. If you think male partner involvement is the problem, the intervention targets male partner involvement. And in a context where we don't think there's a magic bullet, we don't think there's a one-size-fits-all solution, we may need to shift much more to think about multi-component interventions, multimodal thinking. Ooh. I think this is an incredibly exciting area for future research. I think in the next 5 or 10 years, we will have, I hope, massive advances in understanding how to deliver universal ART writ large and to pregnant and postpartum women in particular. And I think that that's better. I think that there's going to be an essential tension that we're going to have to confront, that many people in the room confront already. How do we design and implement services that address the needs of women as individuals, because we're all unique, we're all special, and at the same time, deliver services to massive numbers of patients at scale with efficiency in a resource-constrained environment. And this is not an essential tension that's unique to HRV or ART services, of course, but it's going to require careful consideration. So in wrapping up, where are we headed? So we could decide that we will hear no evil, we will see no evil, and in turn we will speak no evil. We could decide to close the door quietly and carry on with our work. I don't think we'll do that. I hope we won't. But there is hope, because we are not alone, and misery loves company. If you look at the literature on gestational hypertension, if you look at the literature on gestational diabetes, mental health during pregnancy, totally outside of the context of HIV, what you see is that everyone is grappling with this to some degree. The issues faced by HIV and ART are unique, absolutely. But in fact, there are a range of conditions for which people have been thinking for a long time about how to optimize engagement in chronic care during pregnancy and postpartum. And I think there's learning that we could draw from that. And so we're going to need, over the next 10 years, a triad of things. We're going to need research. I'm a researcher, so I'm biased, but I think we are going to need research. We're going to need advocacy, and we're going to need these to inform enhanced policies and enhanced services. There's a retention research agenda that I think in many ways is unique to pregnant and postpartum women. And that research agenda has manifestations at the individual level. We need to understand both the drivers of disengagement, but also the success stories. It's a little bit like the continuum of vulnerability and resilience. We were talking about adolescence yesterday. Why are some women able to be engaged in care successfully for years in dire circumstances, and in the same circumstances, other women struggle? What are the contextual factors involved? And then what groups of factors may we address, through multi-component interventions? And health service and health systems questions are equally critical. How are we going to optimize outcomes, minimize disengagement, with the lowest cost, with the greatest population coverage? And I haven't talked about children. I feel like in a pediatric workshop there are plenty of people to do that. But linking maternal and child health services and health outcomes over time is something that we're starting to think about now, and that is going to be front and center in that agenda. And again, we'll have to balance these individual and public health approaches. And in my closing slide, I have to say, and I've never said this before, and I'm saying it in front of a large group, I think we're missing advocacy. I think there's something missing from this discussion. There are people, maybe they're in this room, but they're not often in the rooms that I sit in. And I think back to advocacy, other aspects of advocacy around maternal health. Alan Rosenfield, I might be dating myself, but Alan Rosenfield was an obstetrician and an activist for maternal health, initially in the context of maternal mortality, And then later, 15, 16 years later, in 2001, in the context of MTCT, note this is not the MTCT that we do, this was single-dose nevirapine that he was commenting on vociferously. And the question was always, where's the M? Where's the mother? Where's the M in MCH? Where's the M in MTCT? And so you'll be unsurprised to hear that I ask, where's the M in option B+? So I'm not a pediatrician, I'm not very smart. And so a friend of mine who's a pediatrician pointed out to me, Landon, you really struggle to spell because there's no M in option B+, but you're sitting in a room of pediatricians, so what about a C? And I would actually turn, based on what Chewy said yesterday, based on what Nigel said yesterday, I think where we're headed is, where's the MCH in option B+? And how do we think about optimizing maternal and child health outcomes using an HIV-centric program, but recognizing that we need to optimize outcomes across the spectrum of health and well-being? So that's everything. Thank you for your attention.